Good evening, everyone. Thank you so much for joining us tonight for this educational webinar on oral health and myeloma, what patients and caregivers need to know. My name is Gabriele Colasurdo. I'm the Manager of Education and Patient Services at Myeloma Canada. Before we get to the presentation, I'll just go over a few things. You know, we're all living in a very, I guess, bizarre world right now, where things are pretty much at a standstill. And here at Myeloma Canada, we're doing our part. We're working remotely for the next little while, you know, to help you know, curb the potential transmission of the virus and protect the people around us. That means we're doing more webinars like the one tonight. We had one yesterday on COVID-19 as well. You can find that on our YouTube channel. We've introduced a new online platform for all of our support group leaders so that they can continue to have support group meetings. Obviously, they can no longer meet in person for the time being. We also have some virtual support groups on Facebook, and you can access those through our website, or if you go on Facebook and do a search for Myeloma Canada support group, you'll be able to find those. So all of our in-person events that were scheduled have all been either postponed or will be adapted to a different format. If you're part of our newsletter, which you probably are since you're signed up to this webinar, you will get notifications on the new dates for that. During this time, if you have any questions or concerns, please don't hesitate to either email us or give us a call. We're here to help. So all of our educational webinars, they're recorded. They're available on our YouTube channel or on our website, myeloma.ca. How do you access them? So if you go to YouTube and you type in Myeloma Canada in the search box and click on the little search icon, you'll get a list of channels. Our channel should be the first one that shows up when you type in Myeloma Canada. You can click here on this red button to subscribe. Every time we upload a new video, you'll get a notification. That way you can stay up to date with the latest that we're trying to bring to you. From our website, myeloma.ca, if you just click on the resources tab at the top right here, a menu will drop down, and then clicking on educational videos, that'll just redirect you to our YouTube channel where you'll get access to all of the videos. Finally, during the webinar, how do you ask questions? So on your GoToWebinar software, you'll notice there's a little gray box that says questions. If you click on this little arrow here at the top left of the screen, the box will open up and you can type your question here where I have the red dotted line. Once your question is typed, you press send. The question will come to me. I will ask our presenter the question at the end of the webinar. Please, if a question comes to you during the webinar, type it in anyways, and we'll get to it at the end. Hopefully, we'll be able to get to all of the questions, but if we don't, then please don't hesitate to email us or give us a call. So without further ado, I'd like to introduce Dr. Erin Watson, who is Deputy Chief of Dentistry at Princess Margaret Dental Oncology. She's also Associate in Dentistry at the University of Toronto. Dr. Watson, thank you so much for taking the time.
Of course, thank you for having me. So this evening, I'm going to be speaking about oral care and dental care for patients with myeloma. Some of the things I'm going to talk about today may make some of you feel a bit concerned because I'm talking to you about the importance of oral health at a time when, at least in Ontario, all dental clinics have essentially been shut down for all but emergency care. So I am going to speak a little bit about dental care during a pandemic at the end of the lecture. I wasn't expecting to talk about that tonight, but obviously it's become quite relevant in the past couple of weeks. But I always reassure patients that dental problems are things that happen over the span of weeks and months and even years when we're talking about gum disease and different types of illnesses in the oral cavity. So don't feel concerned if you come away from this talk and think to myself, oh, I haven't seen a dentist in a couple of years, I should really get in and see them, and then face difficulty in seeking dental care for a few months, because you know nothing falls apart over the span of a couple of months. certainly emergency treatment can be quite important, and that is still available to all patients. So I'll touch upon that a bit at the end. So I do have a conflict of interest to report. I have previously been paid an honorarium for a single lecture that I gave to physicians prescribing denosumab, which is also known as Xgeva. This is a medication very similar to a medicine called Bisphosphonates that many patients with myeloma are taking. So I lectured to them about a side effect from this medication and how to prevent it. And I'm going to be speaking about that actually a little bit today. So I included a picture of myself just so you would have an idea of what I look like, since I am speaking to you tonight without any type of video. That picture is a couple of years old, but I'll convince myself that I still look just like that. So who am I? I'm a clinician investigator and the Deputy Chief of Dentistry at Princess Margaret Cancer Centre. We are a pretty high volume clinic, so we see many patients with multiple myeloma each year. In a typical year, we'll see between 200 and 250 new patients with multiple myeloma. And we typically see patients with myeloma in the context of what we call dental clearance prior to transplant. So many of you, or if you're a caregiver, many of the patients that you've been looking after have been diagnosed with myeloma and have received a autologous stem cell transplant as part of their therapy. And at Princess Margaret Cancer Centre, we have a protocol in place where all patients who are going to be going for autologous transplants come through the dental clinic, and we take a good look in their mouth, we take x-rays, and we make sure that they don't have any infections before they go for the transplant, because during the transplant, there'll be a period of time where a dental infection could cause a significant issue. So that's the context whereby we see most patients with myeloma. And then I know a fair bit about myeloma at this point. I've seen about 350 new patients with multiple myeloma over the past 5 years. So I don't know if you would consider me an expert, but certainly I've seen quite a few patients with myeloma and have gained a decent amount of experience working with these various patients. So I wanted to start by talking about what dental care is important, and this is really amongst different phases of your treatment. As I mentioned, I do see most patients in the context of seeing them prior to a transplant. So if you're a patient or a caregiver for someone with myeloma who is never going to receive a transplant, the things that you need to worry about from a dental care perspective can be quite different than for a patient who is going for transplant. And this also changes for patients who are receiving this medicine that I spoke about earlier, which is referred to as a bisphosphonate. So I will try and kind of talk about how this is relevant for patients in all contexts, but certainly my area of expertise lies with patients who are going to be going for transplant. So at the time that you're diagnosed with multiple myeloma, many patients will go on to receive a stem cell transplant. Some patients don't go on to receive transplant, typically patients who are a bit older or who have different types of illnesses that prevent them from being eligible for transplant. So if you're never going for transplant, you're basically going to be receiving some type of chemotherapy or medicines that are going to try and keep your myeloma calmed down for as long as possible. So this would kind of be the context of how I would think about that your dental care is the same as someone who's undergoing chemotherapy waiting for their transplant. So most patients will receive about 4 to 6 months of chemotherapy prior to going for their transplant. And during this time, it's usually okay to keep getting dental care. In most cases, patients who I see who are receiving chemotherapy leading up to transplant, which is usually a type of chemotherapy called Cyborg-D. Usually, this is a typical regimen for patients with myeloma, which is cyclophosphamide, bortezomib, and dexamethasone. Usually patients are in pretty good shape to receive ongoing dental care, but it is important that your dentist check your blood counts before you go for any type of routine dental treatment. So complete blood counts are measures of different things that you have in your blood that you need to fight infections, to stop bleeding, and to carry oxygen. So the main things that I look at as a dentist are your neutrophil count, where you need enough neutrophils to make sure that you don't get an infection in your mouth after having dental treatment performed. And then also platelets, which is what you need for clotting blood after having dental procedures performed that cause bleeding. So those are the two main things that I look at. And the numbers that you see here on the screen are normal values, but certainly you don't need to have completely normal blood work to have routine dental care performed. So at our cancer center, we typically provide routine care for patients as long as their neutrophil count is above 1.0 and platelet count above about 75 to 100. In the hospital-based setting, I will provide routine care with a platelet count as low as 50, but I probably wouldn't advocate for doing that in a community-based setting, so with a dentist outside of a hospital. But those are things that your dentist can check when you go in to see them, and they can make sure that it's safe for you to have dental care performed. If your neutrophil count were to drop below 1, then we would start thinking about giving you antibiotics before having a dental procedure performed. And if your platelet count starts getting low, below the 75 range, we start worrying about bleeding after dental procedures. And interestingly enough, one of the greatest risk factors for bleeding is actually having a cleaning performed. I think a lot of patients assume that cleanings are a pretty routine and not very risky type of procedure, but cleaning involves getting in between the tooth and the gums in a lot of different locations in your mouth. So sometimes when bleeding starts after a cleaning, it can actually be much more difficult to control than if it was coming from a single spot where you had a tooth removed. So one thing that you should expect if you're diagnosed with myeloma and you go in to see your dentist is that your dentist may not know a lot about your diagnosis. And that doesn't mean that you have a bad dentist or that your dentist isn't very smart. It's just that myeloma is a fairly rare disease, and many dentists may have never seen a patient with multiple myeloma before, nor will they have ever learned about it in school. So you may need to come to your dentist with some information from the doctor who's been treating you for myeloma, usually called a hematologist. And you may need to actually provide the dentist with information that you think that maybe they would already know, and make sure that you're bringing your blood work with you to make it easy for them to treat you. So don't be surprised if you go in to see your dentist and they don't seem to know a ton about your diagnosis or how to safely treat you. So before starting chemotherapy, and as I said, most patients that I see are receiving a type of chemotherapy called Cybor-D. It's usually enough to treat any active sources of dental infection. And by that, I mean things like areas where you're having pain in your mouth, where you have a swelling, if you have a gum boil or a pimple in your gums, or any sharp or broken teeth. And at this point, routine dental care is usually okay, but it's often not necessary, particularly if you're someone who has been going to the dentist on a regular basis. So it'd be quite fine if you didn't go and see the dentist for 4 to 6 months while you're going through chemotherapy leading up to transplant. Now, if you're a patient who's not receiving a transplant and you're just going to be going on chemotherapy indefinitely, then certainly you do want to keep up regular dental care. And if you're somebody that hasn't seen a dentist in quite some time, it's possible that you have an infection in your mouth that you're not aware of. So certainly it's not a bad idea to pop into one of the local dentists and have them take a look at your mouth. So this is an example here of what I mean by a gum boil. This is a little swelling around a tooth that's broken and sharp. So this would be the type of thing that could certainly cause an issue as you're going through chemotherapy, and the type of thing that you would want to have fixed before going in to start your chemotherapy. And just looking at this image, I would think that probably a dentist would recommend removing that tooth. So one time when dental care is extremely important, and this is something that I speak about a fair bit, is before you go on bone strengthening medication. So many patients with myeloma, at least at Princess Margaret, I would say as high as about 95%, will go on a bone strengthening medication called a bisphosphonate. And the easiest way to think about how bisphosphonates work, and I will freely admit that I stole this from a dentist who I work with named Dr. Bob Wood. He has actually retired now, but I thought this was a great example, and I stole this from him a couple years ago, is to think about two types of cells that you have in your bones, and we're going to call them Pac-Man and Lady Pac-Man. So in everyone's bones, you have a bone-eating cell that we'll call Pac-Man that runs around and eats up old, unhealthy bits of bone in your body. And then the bone-making cell, which is Lady Pac-Man, comes and puts the bone back. And that's what keeps all of our bones nice and healthy. It allows children to grow. It allows us to repair bones if they break. In myeloma, sometimes Pac-Man starts to get out of control and Lady Pac-Man can't keep up. So these medications called bisphosphonates are often given to patients to stop Pac-Man from working so that only Lady Pac-Man is working. And this starts to fill up the holes that the myeloma is making in your bones, and it's a very important medicine for patients with myeloma. Usually, these bone strengthening medications are given to you once a month while you're at the hospital through an IV. So they actually take a needle and start an IV in your arm, and they give you either a medication called zoledronic acid or pamidronate. If you're ever not sure about which medication you've been given, usually it takes about 15 minutes to half an hour to get zoledronic acid or Zometa, and it usually takes about 2 to 3 hours to receive pamidronate. Zometa is about 67 times stronger than pamidronate. And then increasingly, we're seeing patients who are being given an injectable form of bone strengthening medication that acts a little bit differently than bisphosphonates, but essentially does the same thing. And that medication is called denosumab, or it's Jiva, and that's about the same strength as Zometa. So what is important before you start on these medications is to remove any teeth that you won't be likely to keep for the rest of your life, which sounds quite drastic, but it's because you'll be at a lifetime risk of a condition called medication-related osteonecrosis of the jaw, which is short form to MRONJ. And the easiest way to explain why this happens is to think about pulling out a tooth, say, with multiple roots. And if you think about how a tooth would come out with multiple roots, it would leave a very jagged and irregular shape of bone in the jaw. And it's actually Pac-Man's job, that bone-eating cell, to come in and eat up all those little bits of bone that are left after the tooth came out. However, in a patient who's been receiving these bone-strengthening medications, Pac-Man is no longer working. And sometimes when you remove teeth, about 15% of the time, things don't heal the way that they're supposed to, and instead patients end up with this condition called medication-related osteonecrosis of the jaw. So sometimes this can happen spontaneously, so that means it can happen on its own, but this almost always happens when patients have their teeth removed. So if you looked at a group of patients with myeloma overall, not a high percentage of patients would end up with this condition. The best studies estimate this risk of this condition developing to be somewhere between 1% and 6%. It's when you actually have a tooth removed or some type of surgery in the mouth where we really need Pac-Man to come in and help heal up that area that patients start running into trouble with this condition. So this is an example of a mild case. This is a patient who came in and told me that they had felt something sharp poking out of their jaw on the lower left side. And what I saw was that there was a little tunnel in the gum here. And this measuring stick that I use to usually check to see if patients have gum disease can actually go through this little tunnel in the gums and it'll hit the bone. You shouldn't have a little tunnel in the gums that hits the gum. A little tunnel in the gums that hits the bone. So this would be considered to be a very mild case of medication-related osteonecrosis of the jaw. This is a case that's a little bit more severe. Again, this is a patient who has a healthy tooth here, who ate something sharp, and they cut their gum down here, and now they have a small area of exposed bone in the jaw. And typically for a patient where I saw something like this, I would probably reach out to the doctor who had prescribed them the bisphosphonate that they're taking and ask if it's possible for them to stop taking it for a month or two. And I put them on a special type of mouth rinse, and often these little areas of bone will just kind of fall out on their own. The gum heals up and the patient restarts on the medication. I apologize for these pictures because I know they're quite gross for someone who's not looking at this used to looking at this on a regular basis. But just to give you an idea of what severe cases can look like, this is a patient who ended up with a dead tooth. This tooth right here was dead, and the infection caused some of the bone here to die and become uncovered. And then this was a woman who was on bisphosphonates for quite some time, who had a tooth removed and ended up with quite poor healing in the area. But I will say that this is extremely rare, and these are the only two pictures that I have of severe cases of medication-related osteonecrosis of the jaw from my 7 years working in my clinic. So that gives you a pretty good idea of how rare this is. So important things to know about medication-related osteonecrosis of the jaw, or MRONJ, which really just means death of jawbone because of a medication that you've been taking, is that your risk of MRONJ gets higher the longer you've been on the medicine for. So if I saw someone who had been on this medicine for 2 doses, I would be much less concerned about how they would heal after pulling out their tooth than if they had been on the medication for, say, 24 doses, so for 2 years. Another important thing to know is that the risk of MRONJ does not really go away after you stop the medicine. We don't have great studies that prove this. A lot of this is based more off of observation. But by our best estimates, we think that these medications live in the jawbones for about 10 years before they're gone, or before even half of them is gone. That's something that's called a half-life. But we, in patients who have been on these medications for a decent amount of time, we kind of chalk this up to a lifetime risk. But what's really important to take away is that the overall risk is low, so it's really not a reason not to take the medicine. It's more so to remember that MRONJ is preventable, and it's preventable by going to see a dentist and taking out any awful teeth that you have before you start on this medicine. And one thing that I would actually mention is that I received a very timely email about 5 minutes before starting this presentation from a doctor who treats patients with myeloma at another hospital in Toronto. And she let me know that a lot of patients are going to be going on an oral form, so a medicine like a pill that you swallow by mouth, of bone strengthener during this pandemic, so that patients don't have to come into the hospital to receive the IV form. And the risk of MRONJ, or this poor healing, in patients who are taking the by mouth form, the pill form of this medicine, is much, much, much lower than it is for patients who are taking the intravenous form. So if you haven't seen a dentist before starting on this type of medicine, and you're going to be started on the pill form, it's much less of a concern than if you're being started on an intravenous form, so the type that you get through a needle in your arm. So I think the most important thing to take away is that you can prevent MRONJ by seeing a dentist before you start on the bone strengthening medication. And the way that we prevent this from happening, because we don't have a good idea who it will happen in, and when it does happen, we don't have a very good way of treating it, is by removing any teeth that we don't think you're going to be able to keep for the rest of your life. It's important to remember that the risk increases with each dose of the medicine that you get, and this risk may level out around 2 to 3 years of taking the medication. That being said, most patients who are given intravenous bisphosphonates usually stop taking, well, usually you get them every month, and you stop taking them every month after about 2 years, and might go down to taking it every 3 months. And then after a year or two of that, you typically stop taking the medicine altogether. And part of the reason we can do that is because the medicine continues to live in the bones and continues to have an effect even after you stop taking it. So what would you expect if you went to go see your dentist and told them that you're going to be starting on one of these medicines, one of these intravenous bisphosphonates? It's important to know that your dentist may not understand the strength of the medicine that you're going to be getting. Lots of patients are on similar medicines to these intravenous bisphosphonates that I spoke about, Zometa and Pamidronate. Lots of dentists will see patients who are on a much less strong form for a condition called osteoporosis, which very simply is when you have holes in your bones. So your dentist might be very used to seeing patients who are on these pill forms of medicine where the risk is much lower, probably around about 1 in 1,000 risk of developing this condition, versus patients who are on the intravenous form where the risk is more like 1 to 6%, and then about 15% when you have a tooth removed. So it might be important for you to tell your dentist that the strength of medication that you're getting is much different than the strength of the medication that a patient's going to get for osteoporosis. And I wouldn't be surprised if your dentist didn't know that. Another thing to remember is that the time for watching and waiting is over. And by that I mean, and I have an example of this later in the presentation, a lot of times you'll have a tooth that's had, say, a root canal treatment performed that didn't go very well, and your dentist has told you about it, and you kind of know it's there, and they said, well, one day when it causes you a problem, we'll go ahead and take it out. That time would be when you're about to start on a very strong form of bisphosphonate for myeloma. So if you know that you have a bad tooth, that your dentist has kind of been waiting for it to bother you before doing anything, now would be the time to act upon that and to take care of that problem tooth. You should definitely ask for a Panorex, and I'm going to show you what that means later on, but that's basically an x-ray that shows your entire jaw so that your dentist can see problems everywhere in the mouth. Typically, when you go in for your cleaning and your dentist takes x-rays, they're actually only looking at areas between the teeth where they're looking for cavities, and they're not necessarily looking at the tips of the roots of the teeth and everywhere in the jaws to look for infections. That often only happens the first time that you go in for a dental appointment at your first visit. So you may have to specifically request a Panorex, and your dentist may want to take a lot of x-rays, and that's fine. Don't be surprised if they need to take a lot of x-rays to get all the views that they need of the teeth to make sure that they're not missing any infections. And it's always okay to ask for a second opinion, especially where dentists have been seeing you for, say, 20 years. They're going to feel emotionally invested in your teeth. You're going to feel emotionally invested in your teeth. And sometimes seeing a dentist who hasn't been your regular treating dentist for such a long period of time can actually help you to make a little bit of a less emotional decision about your teeth, which is always important in the context of these types of medications. So this is an example of x-rays that your dentist takes when you go in for your cleaning. So this is the top, this is the bottom, this is your right back teeth, and this is your left back teeth. And this is an example of a patient who has some bone loss. They have a big hole underneath a filling right here. But other than that, things don't look too bad. So when you go into your dentist for your regular cleanings, these are the types of x-rays that they're taking. And oftentimes at Princess Margaret, I'll see patients who will say, well, you know, I've been seeing my dentist regularly. They take x-rays all the time. I don't need any other x-rays taken because my dentist, you know, keeps a good eye on my teeth. And certainly this dentist who, you know, who's been taking x-rays to check for cavities is doing the right thing, but you want your dentist to be looking at your teeth in a slightly different way before you start on these medications. So if I go to the next slide, this is the exact same patient, and this is something called a Panorex. So this is what I was saying that you should ask your dentist to take. And this is the top of the patient's mouth, the bottom patient's mouth, the left side, and the right side. And I'm going to show some close-ups, but what we suddenly see is that this tooth here is actually infected. And in the last view, we just saw this area here, and you couldn't see that infection. And then I would look at this and I would say, oh, it looks like maybe there's an infection here. I want a close-up of this tooth. This tooth has had a root canal treatment. I want a close-up of this tooth. So I take some more x-rays, and suddenly what I see is that this tooth on the lower left side, which corresponded to the first image that I showed you, where all we could tell was that there was a hole under this filling, this tooth down here has an infection, has lost pretty much all of the bone around it. Same thing with these bottom front teeth. this tooth has lost pretty much all of the bone around it and is basically sitting in the gums. And then this tooth up here that has a crown on it that looks perfectly fine in the x-rays that checks the cavities actually also has an infection, which is pretty common in teeth that have crowns or caps put on them. And then this patient had also had a root canal treatment performed in the past. And you can see here, this big dark spot is an infection in the bone from a root canal treatment that never healed. So we basically go from 2 x-rays checking for cavities where we notice one hole to suddenly finding 1, 2, 3, 4 infections. And not to say that this is the case in most patients. Obviously, I chose a good example of this to show you. But certainly this is something that we see fairly commonly at the hospital, especially in patients who are going to be starting on these bone strengthening medications. So it is important to let your dentist take the x-rays that they need to take to make sure you don't have infections in the mouth and to make sure that any of these types of issues are being dealt with before you start on the bone strengthening medication. And there's different ways of dealing with these types of issues. In this example here, you could have a root canal treatment to get rid of the infection that's around the tip of the root. In this case, you would think about performing a kind of reverse root canal where sometimes a specialist in root canal treatments can go and actually remove the infection that's in the bone and fill up the tooth from the tip of the root downwards. And then for these teeth that have quite a significant amount of bone loss, there you'd be more thinking about removing teeth. This is an example of a patient who I saw before a transplant. So before transplant, because patients' immune systems are going to be weak for a period of time, we often try and remove infections in the mouth. And this was someone who had seen their dentist to be cleared, so to make sure they didn't have any dental problems before they started on their bone strengthening medication. And then they came to see me before the transplant. And they had seen their dentist. The dentist had said that everything looked okay, that there was a tooth that they knew didn't look great, but that had been like that for a long time. So they were going to wait and do something about it if it ever caused a problem. And again, this is the top, the bottom, the left, and the right. And you can see these arrows pointing to this tooth that I was concerned about. And when I go and take a close-up x-ray, I can see that the root canal treatment that was performed on this tooth in the past wasn't successful, and that there's quite a bit of chronic, so long-standing infection in the bone in this area and in this area. So for me, that's a concern for someone who's going for a transplant because I don't want to leave infection in their mouth. But it's also a concern because I'm really not sure if this patient is going to be able to keep this tooth for the rest of their life. So this would be a tooth that I would definitely recommend removing before starting on a bone strengthening medication, because the risk of it not healing well if we were to pull out the tooth is reasonably high. So that's what I meant when I said that kind of the time to watch and wait is over. So how can you prevent medication-related osteonecrosis of the jaw or merange? It's by changing the way you and your dentist think about teeth after you start on the bone strengthening. So before starting on the bone strengthening medication, you make sure that you remove any teeth that are bad before starting on the medication. And then after you start on the medicine, you want to avoid pulling out teeth or doing any other type of surgeries in the bone of your mouth, even if you cannot rebuild the tooth. So a lot of times my patients will go and see their dentist and they'll have a tooth that's broken, and the dentist will look at it and say, oh, I don't think I can do a great filling on that tooth. We should pull it out and place an implant. And I'll see the patient and they'll say, well, no, you've been on this bone strengthening medication for a year. It's better for us to get a root canal treatment on the tooth and then cut the top of the tooth out. Cut the top of the tooth off and just leave the roots in place so that the tooth won't become infected but doesn't need to be pulled out. That being said, there are times when you cannot avoid pulling out a tooth. And unfortunately, most government plans do not cover root canal treatments for patients with myeloma who've been on these bone strengthening medications. So sometimes you also can't afford to get a root canal in a tooth and end up in pain and needing to pull a tooth out. So again, what I was alluding to earlier is that your dentist may not understand the strength of the medication that you're going to be getting or the strength of the medication that you've been on. And they may say something like, oh, don't worry, I've seen lots of patients who are on these medicines for osteoporosis. I pull out teeth all the time. It's not a problem. And in that case, it would be important to let them know, well, this medicine that I'm on is actually a lot stronger than what you're used to seeing. And then, as I also mentioned, your dentist may have a hard time accepting imperfect dentistry. So they may have a hard time looking at a tooth and accepting that they may have to do a not so great filling on it. But in a case where I'm worried about a patient having ronge if I pull out their tooth, I would certainly prefer a bad filling to pulling out a tooth. So I will freely admit that I perform bad fillings all the time to prevent pulling out teeth in my patients who've been on these bone strengthening medicines. So this is an example of what I mean when I say getting a root canal and then cutting the top off the tooth. So up here, this is a patient's upper right canine or eye tooth. So the third from the front, and this big black spot here is a big hole that's opened up underneath this cap on the patient's tooth. And they were having pain in this tooth, so we went and we sent them for a root canal treatment, and then we cut off the top of the tooth and we seal over the spot where the root canal treatment happened. Root canal treatment basically just means removing the blood vessel and the nerve inside of your tooth so that it can no longer feel painful and so that it can no longer become infected. And then we seal over the spot where the root canal happened, and you can usually build a nice denture on top of these types of teeth, or sometimes you can build a bridge, which is basically caps with teeth, false teeth suspended in the middle over top of the spot where you're missing a tooth. This is another example. This patient had a very badly broken down molar in the back. This is the upper right first molar, and they were having pain in this tooth. And I have a magical root canal specialist that I send my patients to, and they did a great root canal up here. And then I remove this temporary filling that they placed and place a permanent filling. And if this patient feels like replacing this tooth, we can make a denture, or we can put a cap on this tooth, and float a false tooth in the middle, and that's called a bridge. So it is certainly possible to avoid pulling out teeth in many cases if you are at risk of medication-related osteonecrosis of the jaw. And because we don't have a good way of treating it when it happens, this is how we try and prevent it from happening. So what happens if you get ronge? About 20 to 30% of cases will get better. And by that, what I mean is that typically when a patient gets ronge, we reach out to their doctor who's been prescribing them this bone strengthening medication, and we ask if they can stop it. And you may wonder why we're doing that, because a little while ago I told you that the bone strengthening medication lives in the bones for many years before even half of it's gone. So what's the point of stopping it? But in a situation where it's not going to hurt your myeloma by stopping the medication, we stop it because it means that you're going to receive further doses. You're going to avoid receiving further doses. Because remember, the longer you're on this medicine for, the greater your risk of developing ronge is. So if we can avoid giving you more doses of the medicine, that is preferable to keeping you on the medicine. So when we stop the medicine, in about 20 to 30% of cases, it gets better. And by gets better, what usually happens is some gum will grow underneath the area where the bone is dead and kind of kick out that piece of dead bone, and then the gum just kind of heals over. And in some cases, we refer to a oral surgeon who actually does surgery in the area to remove the area of dead bone and to try and cover the gum over top afterwards, and it can get better. Most cases, however, will tend to wax and wane. And what I mean by that is that they get better and worse over time. So I have many patients who have a small area of bone exposed in their mouth, and sometimes that area will become infected and they need to go on antibiotics, and then it gets better, and a year or two will go by where the area doesn't bother them. So that's what we often see. And then if possible, like I said, you'll stop taking the bone strengthener because this just avoids further doses and being at higher risk of developing this condition. So in a patient who is actively on treatment, the importance of dental work really depends on what stage of treatment you're in. So we started the discussion by talking about before chemotherapy, and then there's obviously patients who are before transplant, which is most of the patients that I see. There's patients during transplant, after transplant, and patients who are on long-term medicines. So before transplant, you want to treat any tooth infections that could cause a problem during your transplant. So this is when we go a little bit beyond the pain, swelling, and gum boils that I spoke about at first, and now we're dealing more so with infections that you may not feel. So if you go to see a dentist before going in for transplant, I would expect them to do a full exam of all your teeth, including x-rays. Again, you want the dentist to take a Panorex. And again, the time to watch and wait is over. So teeth that you know are not so great that your dentist has been kind of keeping an eye on are usually best dealt with before going for transplant. And again, your dentist should be checking your complete blood counts. Now, during your transplant, you will be at higher risk of developing infections because your white blood cells, which you need for fighting infections, might be lower, and you'll be increased risk of bleeding because your platelets, which is what you need for clotting blood, will be lower. So during a transplant, we only treat dental emergencies, and that's why it's important to deal with any teeth that might cause an infection before your transplant, because the infection that you develop during a transplant may be very difficult to treat if your white blood cells are too low or if your platelets are too low. So it is very important to check your blood work. After transplant, most patients have their blood counts recover within a month or two after the transplant. And if you receive a transplant at one of the major cancer centers, they typically have a dental clinic, and the dental clinic will tell you when it's safe to go back to see your family dentist for regular dental care. So what's important when you start going back to see your dentist for regular dental care is that you make sure to go for regular checkups. You want to catch problems when they're small and still easy to treat, as opposed to waiting to go see the dentist when you're in pain, because typically when you go see the dentist when you're in pain, that means that you're dealing with having a tooth removed or dealing with some type of root canal or some other more expensive or invasive treatment. Feedings are very safe, especially in patients who are not on bone strengthening medications. In patients who are on bone strengthening medications, sometimes the dentist or gum specialist will recommend a cleaning where they actually lift up the gums and clean the teeth more thoroughly with the gums out of place. And that type of cleaning should be avoided in patients who are on bone strengthening medications. Fillings are okay, x-rays are okay, crowns are okay, root canals are okay. It's really only surgery that's an issue for patients who are on bone strengthening medications. For patients who are on long-term medicines, many patients will be placed on a medicine that helps keep their myeloma under control, especially after transplant. Many patients go on a medicine called Revlimid, and Revlimid can sometimes cause blood counts, especially neutrophil counts, to be a little bit lower than what we expect. And oftentimes the amount of Revlimid that you have to take changes over time. So this can make your complete blood counts change, and that's why it's very important that even when you get sent back to see your dentist for regular ongoing care, that they be checking your blood counts on a regular basis, because what your blood counts looked like 6 months ago, they may not look like 6 months later. So what other things can happen in your mouth? So outside of making sure that your teeth are in good shape before you start chemotherapy or transplant or bone strengthening medications, there are some other things that can happen in the mouths of patients with myeloma that are a little bit different. So sometimes, and this is fairly rare, myeloma can actually appear in the gums, and it usually looks like a gum swelling or abscess. So if you went to go see your dentist with something like this, I would be very surprised if they had ever seen anything like this before. So it's likely that they would say they didn't really know what was going on, and that they would send you to a dental specialist called an oral pathologist. And then that doctor would take a little piece of the swelling and they would confirm that this is actually myeloma in the gums. And then you might need to change your myeloma treatment. So this is an example of a patient who came to see me who had thought that they had a gum abscess, and they went to see their dentist, and their dentist wasn't too sure. So they sent them to see me, and I took a little piece of this and I confirmed that this is something called a localized plasmacytoma, which is really just a fancy way of saying that the patient's myeloma had come back in their gums in this area. And there was no treatment needed for that. The patient, I should have put the picture that came after. I thought I did. But anyway, the patient was restarted on a medicine, on a chemotherapy for myeloma, and this swelling went away all on its own. Sometimes myeloma can cause your tongue to become larger through a process called amyloidosis, which is basically where a protein starts to build up in the tongue. And this can make it feel like your tongue is swollen or like your teeth are pressing into your tongue. And you usually don't need to do anything about this. We typically don't even take a piece of the tongue to confirm that this is what's going on. It's more, we see this happening and we say, oh, this is amyloidosis. And again, this will often get better and worse as you go through treatment. So this is an example of a patient who has amyloidosis of the tongue and myeloma, and you can actually see how their teeth have made little indents into the tongue because the tongue is pressing into the teeth because the tongue is larger than it typically is. The last thing that myeloma can do is that it can cause holes to appear in your bones, which we spoke about earlier, and sometimes you can see this on x-rays. And you would expect your dentist to maybe seem worried or surprised by this because, again, this is probably something that they've never seen before. So this is an example of a patient with a normal bone pattern. So this is the top of the jaw, bottom of the jaw, left side, and right side. And then in the next slide, this is a patient with myeloma in their bones. So I'm going to switch back. And you can kind of appreciate that this is all a fairly continuous gray type of look. And when I switch to the next picture, you start to see lots of little holes in the bones. And this is a very common thing to see in myeloma. So if you ever took an x-ray and your dentist said, oh my gosh, you know, you have a bunch of holes in your bones, I don't know if I need to do anything about that, you could tell them that that's a normal appearance for the jawbone of a patient who has multiple myeloma. There's another example. These holes are a little bit more pronounced. And in case you're wondering, having holes like this doesn't put you more at risk of breaking your jaw. It's usually filled with a type of tissue that is quite spongy and holds things in place pretty well. And then if I flip to the next picture, you'll see I'm going to show you an example of a patient who's been on bone strengthening medication, and you'll actually see how some of these holes here start to fill up. So some of these holes are smaller now because this patient's been taking bone strengthening medication and the bone's much thicker now around the teeth. So the last thing that I'm going to touch upon tonight is how do I get dental care during a pandemic? So as I mentioned, most dentists are closed right now. But if your dentist is closed, they will have a number on their answering machine for you to be able to call in if you're having an emergency. So a lot of the rules for dentists are changed right now. Dentists are allowed to call in prescriptions over the phone right now. So normally a dentist has to physically see you to be allowed to prescribe you an antibiotic. But in this case, if you call your dentist, they're actually allowed to call you in a prescription over the phone because most dentists are not open to see patients. Dentists are allowed to see patients who have true dental emergencies. And a true dental emergency means an injury, like you fell and you broke a piece of your jawbone, or a large piece of your tooth has come out. If you have pain that's not being controlled by medications that you got from a pharmacy, if you have bleeding that's been going on for a long time, or if you have a swelling or an abscess. So dentists are allowed to see patients with any of these emergencies, but they need to have proper personal protective equipment. And what that means is that they need to have a special type of mask and goggles and gowns that make it safe to see patients, because dentists when we're dealing with emergencies, often create something called aerosols, which is basically when liquid gets kind of stirred up and is floating around in the air. And for things to be safe for dentists to perform that type of treatment right now, they need a special type of mask called an N95 mask. And if any of you have been reading the news a lot frequently, N95 masks are in very short supply. So not many dentists have access to this type of equipment. So even though a dentist is allowed to see you if you're having an emergency, they may not have the right equipment to be able to provide that care. So the first thing I would recommend if you're having a dental emergency in this period of time is to call your dental office, and they should have a number for you to call in case of an emergency. I would definitely recommend avoiding going to your local emergency room unless you have severe trauma, like you fell and you broke your lower jaw, or you have an infection that's causing swelling in your neck and you're having difficulty breathing. Those would definitely be reasons to go to the emergency room. But otherwise, I would definitely avoid going to the emergency room right now and instead just call your dentist, because if you go and see a medical doctor, their only real treatment that they're going to be able to provide you is pain medications and antibiotics, which you can get from your dentist anyway. And then, unfortunately, because I'm from Ontario, I've posted something that's fairly Ontario-centric. But the Royal College of Dental Surgeons of Ontario does have a list of dental practices that are open for emergencies during the pandemic who do have a supply of personal protective equipment so that they can provide safe emergency treatment for you. And then for those patients who have previously had a stem cell transplant or who've been treated at a cancer center, most cancer centers across the country are still providing care for patients with myeloma, particularly patients who are on bone strengthening medicines, and do have access to this type of equipment that makes it safe for dentistry to be performed. So if you're one of the patients who's already been seen in one of those cancer centers, you could certainly reach out to the dental clinic there and likely be able to receive safe care. So that concludes what I was going to speak about this evening. I'm happy to open up to any questions that you may have.
Thanks, Dr. Watson. That was some very useful information that we received. So we did get a few questions. So the first question I'm going to ask you is about, we mentioned, tooth extractions only when, they're absolutely necessary, try to avoid them. So let's say you need to get a tooth extraction. What's the protocol for how long someone has to be off of these bone strengthening medications before the tooth extraction happens?
So that's a really tricky question. And if I could answer that question, I would be an absolutely amazing dentist. But the real answer is that we really don't know. So we do have patients who've been off these medicines for years, and we go and remove their teeth and things heal quite well. So that does give us a sense that if you've been off the medicine for several years, that maybe the risk of this condition developing is lower. The same thing I would say too for patients who've only received a few doses of the medicine. If you'd only received a few doses, then I'd be much less worried about poor healing than someone who had been receiving the medicine for a couple of years. That being said, we almost never remove teeth in patients who are on these medicines unless we really need to. And when I say unless we really need to, that's usually an emergency. So typically when I have to remove a tooth on a patient who's been on these medicines, they are having a dental emergency, and the risk of leaving this infection in the patient's mouth is greater than the risk of developing this condition. So in those cases, we would reach out to the doctor who'd prescribed the medicine and ask if they could stop giving it to the patient, but we would probably take out the tooth that day because of the infection that was present. So typically the nature of the reason for taking out the tooth decides how quickly we would take out the tooth. When I see patients who have been on these medicines, who come and see me before transplant, and I recommend taking out teeth that are infected to protect a patient during their transplant, even if they've been on the medicine for a couple of months, I'm usually not so concerned about when the last dose was received. I'm more concerned about just asking that the medicine can be held until I see that the area where I take out the tooth is able to heal. And actually, most patients who go for transplant have these types of medicines stopped during the transplant period and then for a few months after. So that actually gives us a nice window of time, usually of about 4 to 6 months, where you wouldn't be receiving this medicine anyway.
Okay, great. Thank you. The next question, we talked about 3 different types of bone strengtheners, 2 of them which were bisphosphonates. When it comes to complications, is there any one that of those 3 that would cause less complications, or they're pretty much all the same?
So pamidronate is estimated to be 67 times less strong than Zometa. Zometa and denosumab are about the same potency or the same strength, even though they act in slightly different ways. So in our experience, the risk of this type of complication is lower in a patient who has been taking pamidronate. Another thing to know is that denosumab is a different type of medicine. It's not a bisphosphonate. It's something called a monoclonal antibody. And those are supposed to live in the body for much less long than the bisphosphonates do. So if you stop taking denosumab, theoretically, within about 6 to 9 months after stopping taking that medicine, it would no longer be present in your body. And when we look at studies of patients who have teeth pulled out and who develop MRONJ, who are on Zometa versus patients who are on denosumab, we see that the MRONJ seems to resolve in about 20% of the patients on Zometa and in about 30% of the patients who are on denosumab. So definitely pamidronate is less, we see less complications in patients who are on pamidronate. And then if you look between Zometa and denosumab, the complication rate is about the same, but it seems to have a little bit of a better ability to heal in patients who are on denosumab.
Awesome, thank you. The next question has to do with, we talked a lot about transplant, but for someone who hasn't, who didn't go through a transplant, you had mentioned that you should still continue going to the dentist, and so is that kind of like on twice a year, once a year? What's the recommendation on how often someone should see a dentist who hasn't had a transplant?
So I do try and be a realist, and I understand that often what dictates how often a patient's going to see the dentist is what their insurance can cover, because dentistry is certainly expensive. But in an ideal world, you would be seeing the dentist every 6 months or so, and having x-rays, depending on how much at risk you are of developing cavities, every year to 2 years. That being said, some patients who are more at risk of gum disease get cleanings every 3 to 4 months, and that's much better for preventing issues. So it's really a bit of a case-by-case basis, but at the very least, I would certainly recommend every 6 months if your insurance covers it and if it's financially feasible to do that. If that's not possible, then certainly every year is better than nothing.
Awesome, thank you. So this question, I think I could skip this because we already answered it in the presentation. Let's go with the Panorex. So if someone, for example, has had a Panorex at your clinic at Princess Margaret, is there a need to also get a Panorex at their local dentist?
No, we typically only recommend getting the Panorex every 3 to 5 years or so. And then if, a patient's about to be started on bone strengthening medication or go for transplant, if the Panorex is more than 6 months old, we would probably repeat it. But no, if you've had a Panorex taken, you don't need to repeat it at your family dentist. And I can't speak for all clinics, but you should be very easily able to get access to your Panorex and to get it sent to your family dentist. You just need to fill out a couple of forms giving the clinic permission to release the Panorex to your family dentist.
Great, thanks. So you had mentioned a few times that you try to get rid of, before a transplant, we try to get rid of the teeth that you don't plan on keeping for your entire life. When it comes to wisdom teeth, someone who has good oral hygiene and someone who their wisdom teeth are not causing any problems, are those teeth that should be removed?
So we almost never take out wisdom teeth prior to transplant. In my experience, most wisdom teeth won't cause an issue in a patient during their transplant. The wisdom teeth we're least concerned about are ones that are deeply buried in the bone that you can't even see and don't really even know you have, or ones that are fully grown into the mouth that are basically acting as any other teeth. The trickiest ones are ones that are half grown in, where the gums can sometimes become infected around the tooth. But most patients we see with myeloma who are going for transplant are around 60 years of age. So if you still have your half grown in wisdom teeth at 60 years old, and we can assume that you've had those teeth for about 40 years, that tells me that for 40 years those teeth haven't caused a problem. So it's quite rare that we recommend taking out wisdom teeth before transplant, because it's a pretty invasive surgery and takes a lot of time to heal, and the risk of developing an infection in the gums doesn't warrant the risk of potentially delaying the transplant. Now, in patients who are going to be started on bone strengthening medications, sometimes we will pick on wisdom teeth, even ones that are fully grown into the mouth. So that's a bit of a different situation. And if I see someone who still has their wisdom teeth and they have some bone loss around them, or big fillings on them, or cavities on them, and they don't have any problems anywhere else in the mouth, that tells me, this is the only spot where you've had an issue, so it might be a better idea to get the wisdom teeth taken out before starting on the medicine, rather than taking the risk of having to take them out in the future. And part of the reason we feel that way is because the site of the mouth where you're most likely to develop merange is the back of the lower jaw, so the area of the wisdom teeth in the lower jaw.
Awesome, thank you. So we talked about transplant and all that, but we didn't really touch on relapse. So someone who has myeloma, who's taken 2 years of bisphosphonates, suddenly has a relapse. Should there be a Panorex at that point, or it's not necessary?
So if you've relapsed and you're going to be restarting on chemotherapy, typically I would say that it's not necessary. If you've relapsed and you're about to go for transplant again, then I likely would take a Panorex and just make sure that nothing significant has changed. If you've relapsed, I would probably deal with any type of active infection. So if you had any pain or swelling or a broken tooth, I would probably have that addressed.
Okay, so we have just about 3 questions left. Are you still okay with time for 3
Yeah,
questions?
absolutely.
Okay, awesome.
I don't have my family's been making the same joke over and over that if we check our calendar, and no, we have nothing going on right now.
So the next question, how about someone with myeloma and that they want Invisalign braces or Charades? Is there a worry when it comes to that?
Actually, that's an awesome question. So that makes me wonder why I didn't think to mention that in the presentation. So very smart, whoever asked that question. So Invisalign basically works the same way that braces do. So if you are just somebody who has myeloma, there's no problem with getting braces or Invisalign, as long as your teeth are otherwise in a healthy state, and you're not. I wouldn't go necessarily to get braces immediately prior to a transplant or anything like that. But if you've been taking bone strengthening medicine, teeth move with braces by actually using Pac-Man. So that bone-eating cell that I was talking about, when you move a tooth with braces, the braces basically pushes your tooth against the bone, and that sends a message to Pac-Man to start eating the bone in the front of the tooth, and Lady Pac-Man puts the bone back behind the tooth, and that's how teeth actually physically move from braces. It's not that they're necessarily moving in the bone, it's more that at the front of the tooth, Pac-Man's eating the bone, and at the back of the tooth, Lady Pac-Man is putting the bone back, and that's how the teeth physically move. So when if you're a patient who's been on these extremely strong bone strengthening medications, what they've seen when they try and put braces on these patients is that the teeth just don't move, because you don't have the things that you need working in the bones to allow the teeth to move in the jaw. Again, There are no great studies whatsoever to support this, because they're just, nobody ever took 100 patients with myeloma and gave them all braces and bone strengthening medications to see what would happen. But if you went and did a search of all the papers that have been written about this, a couple case reports come up. So just descriptions of specific patients who were on these bone strengthening medications, who got braces and then ended up with spontaneous, so not because of tooth being pulled out, but bone that became exposed all on its own, just because of braces and these bone strengthening medications. So I've only ever seen one patient with braces who was on bone strengthening medication, but my recommendation to them was to take the braces off and to stop getting that type of treatment.
Fantastic. So this is it's a two-part question. So are there any alarms or warning signs for Mirage that someone could say, oh, there's some a warning sign that might be happening? And kind of related, I guess. Let's say someone's had an extraction and it's looking like it's healing normal, and then all of a sudden there's some kind of ridge development close to the site of the extraction. And so, how long does it take for? I guess it's a three-part question. How long would ONJ take to develop after such a surgery?
So just repeat the first part first. I'm going to get you to probably.
Warning signs for ONJ are
Right.
there any early warning signs?
So not really. And to be honest, I always tell patients who are on these bone strengtheners, don't start going about life worrying that all of a sudden you're going to wake up one day and your jawbone's going to have fallen apart, or all your teeth are going to have fallen apart or fallen out. That's really not how this happens. In the rare cases where ONJ happens on its own, it's usually just a little sharp area of bone that starts poking out through the gums. Most cases really happen after having a tooth pulled out. Warning signs that you may be starting to develop it if you've had a tooth removed are that it feels like the spot where the tooth came out hasn't been able to fill. If you feel sharp, jagged bone poking out from the area, if the area feels swollen and there's kind of a liquid coming out of the area. And in rare cases, it can sometimes happen where it starts to feel like you're numb on one side of the jaw, or like teeth are becoming loose on one side of the jaw, but that would be a much more extreme case. And then can you give me part 2 and part 3 again?
So I think we pretty much covered it all in the response. So I don't think we need to go further with that. So yeah,
okay,
it was covered. So two small questions. So now because of the situation we're living in with this pandemic, a broken tooth, is that considered something that should be resolved now, or something that can probably wait?
I would say probably wait, but it would be a good idea to call your dentist and just kind of describe what's happened. But even at Princess Margaret, where we do have the ability to treat patients, and where we have the proper protective gear, and where we're allowed to provide care in patients who are on bone strengtheners, where we feel like there's a risk of them developing ONJ, it would be extremely rare in this present situation where I would recommend filling a tooth that was broken. Just because you usually have to generate what we call aerosols to do that. And unfortunately, it just doesn't necessarily qualify as emergency treatment. So your best bet in a situation like that would be to leave it, unfortunately. And then if it starts to hurt, or if you start to have swelling, or if the tooth is very sharp and is cutting into your mouth and causing pain and bleeding, in that situation, you'd be able to seek dental care. And I'm not going to pretend that that's ideal by any stretch of the beans, but that's the unfortunate reality right now.
Okay, thank you. So so is there a timeline for someone who's had an extraction on how long after something like ONJ might happen, or is 2 months go by, you're out of the woods, or kind of thing?
I would say that about 95% of the time, we can tell pretty quickly whether or not the area where we took out the tooth is going to heal or not. So you take out the tooth, we see the patient back a couple weeks later, and if the area is still completely exposed and you can just see it looks like you just took the tooth out and there's a bunch of dead bone in the area, I know that that area is just not going to heal well. If I see that gum has already started to grow into the area and that it's starting to heal over, then I start to feel pretty confident that this area is going to heal. I will say that there are some times where months or even years out after having a tooth taken out, we'll take an x-ray and we'll see that patient has on the x-ray some signs that they've developed this non-healing condition, and that we just kind of we see that on the x-ray and when we inform the patient and tell them that it's there. But for the vast majority of the cases, we know pretty quickly after taking out a tooth whether or not it looks like the area is going to heal.
Awesome, thank you. So we're at the last question now, and I think it's more of a repetition than actual question. So Panorex again. How often? So I think you said about 4 years or so before?
So realistically, I think if you looked at guidelines that radiologists made, they would say that you should be taking a Panorex. I think it's every 5 years. We will typically take a Panorex if a patient's medical condition indicates it. So we'll take it more frequently than that in a patient who's getting a transplant or a patient who's being started on a bone strengthener, because I'm looking for problems in those types of cases. Otherwise, you typically will only get a Panorex when you go to see a dentist for the first time or every 5 years. That being said, I don't know how many practices actually actively keep track of when the last time you had a Panorex was and whether or not you would actually be getting it every 5 years.
Okay, thank you. Dr. Watson, thanks again for taking time out of your schedule to speak to us today and educate us about dental work and the dental problems for people living with myeloma. It's very appreciated. And I wish you a very good night.
Thank you so much. And thank you everyone for joining late on a Friday evening.
Have a great night. Bye-bye.
You too. Bye.